Welcome to a national lung cancer screening model for hospitals and health systems. If Kentucky can do it, anyone can. My name is Merlene Tucker, and I'm running this Dialogue for Health web forum. Thank you to our partners for today's event, the Lung Cancer National Training Network, the Kentucky Cancer Program, the University of Louisville, and the Bristol Myers Squibb Foundation. Now I'd like to introduce Celeste Worth, the moderator of this event. Celeste has over 20 years of experience in cancer control and provider education and is the director of the LUCA National Training Network at the University of Louisville. She is also a tobacco treatment specialist and master certified health education specialist. She was previously a co-investigator for the provider education component of the KY Leads Collaborative and the professional education and training manager for the Kentucky Cancer Program at the University of Louisville. Celeste, welcome again.
Thank you so much, Merlene. Hello, and welcome to the 5th webinar in the LUCA National Training Network series. We are very pleased that over 600 people have registered for this event today, and we appreciate you taking the time to join us. I want to start by thanking our co-sponsors for today's webinar, Kentucky Cancer Program, University of Louisville, and the Bristol Myers Squibb Foundation. For those of you who have not attended one of our webinars, LUCA National Training Network at the University of Louisville can be a free resource for you. And I'd like to share some additional information to let you know about us in a little more detail. The LUCA National Training Network, which goes by LUCA, is funded by a grant from the Bristol Myers Squibb Foundation. In addition to providing education and training directly to providers and other health professionals with webinars like this and a comprehensive online course, we also provide assistance materials and other resources for those who are educating health professionals on topics related to care for those at risk for lung cancer or those who have been diagnosed. Our award-winning website at lucatraining.org has over 350 tools and resources for healthcare providers and patients. We encourage you to check it out, and please contact us at the email on this slide, lucatraining@louisville.edu, with any questions or requests that you may have. To get important updates and announcements about new offerings, tools, and resources for healthcare providers and patients, we invite you to follow us on Facebook and Twitter. We are also conducting live tweeting during today's webinar, so feel free to follow on Twitter and add comments with hashtag LucaWebinar. Now I'm extremely pleased to introduce our expert speaker. Dr. Michael Gieske grew up in Edgewood, Kentucky. He can remember when ground was broken for St. Elizabeth Hospital South, affectionately known at the time as the Mecca in the Meadow. He got his first healthcare job there in the laboratory as a phlebotomist and lab technician in 1977. It has brought him a strong sense of pride and joy to see St. Elizabeth Healthcare grow to its present status, setting many trends for the region and the nation. St. Elizabeth now has 6 hospital sites and over 1,000 beds. He is especially excited to be part of the promotion and development of the region's largest cancer care center, which will inevitably enrich and improve the lives of patients and families in the community he grew up in, as well as an expanding geographical footprint. He graduated from University of Louisville Medical College in 1984, then completed his family practice residency at St. Elizabeth Medical Center in Edgewood, Kentucky in 1987. He subsequently began his career in family practice, joining a small group of 4 other independent family practitioners in Florence, Kentucky. He was instrumental in growing a large group of 26 independent practitioners across 5 sites that ultimately transitioned into the larger hospital-based program, St. Elizabeth Physicians, employing over 150 primary care providers. In addition to his daily practice, he is lead physician at his site in Fort Mitchell, Kentucky, and the East Division Physician Director of Primary Care, overseeing 12 sites. As a spinoff of this director role, in 2016, he began to take part in fostering the growth of the low-dose CT lung cancer screening program at the community-based St. Elizabeth Hospital. He was appointed Director of Lung Cancer Screening November 2019. Additionally, he is Medical Director of Virtual Health, lending to innovative approaches to patient care that will further assure the future success of St. Elizabeth Healthcare. His interests include gardening, oil painting, kayaking, hiking, backpacking, and travel, all of which I know he just returned from, as well as spending time with his family, including his wife of 30 years and his 25 and 27-year-old daughters and 1-year-old grandson. Dr. Gieske, welcome.
Thank you, Celeste, for that gracious introduction. I very much appreciate this opportunity to address lung cancer awareness, screening, and detection on a national level. The title for this presentation I can't really take credit for, but it's kind of a tongue-in-cheek, lighthearted look at, Kentucky and the fact that we're usually the bottom of about every list there is when it comes to healthcare. But the more important take-home message, hopefully by the time we're done, is that there is a lot of hope, not only for Kentucky, but also for our country and for the world as a whole. We're going to set the bar for lung cancer screening, and we're already making a significant impact. And hopefully by the time I'm done here, we'll be able to appreciate that further. St. Elizabeth began in 1861. And I can't add a whole lot more to the introduction that Celeste just gave. I grew up just right down the street from St. Elizabeth South, which is our flagship hospital in Edgewood, Kentucky. We're situated in northern Kentucky in the tri-state area of Ohio, Indiana, and Kentucky. And we have affiliations with the Mayo Clinic, the University of Kentucky Markey Cancer Center, and the Kentucky Health Collaborative, a 10-system, 60-hospital affiliation dedicated to improving the health of Kentuckians. We have 7 hospital facilities, and we're in a state of growth. We started about 11 years ago with our physician group, St. Elizabeth Physicians, and we've had steady growth since that time. We serve over 350,000 patients. We have 642 providers, 150 of which approximately are primary care providers, and we have about 2/3 physicians and about 1/3 advanced practice providers. We served over 1.6 million patients in 2019. I'd be remiss if I didn't mention our new Comprehensive Cancer Center. It seems like 2 years was a very long time ago when we broke ground, but we're very excited about this. This is going to be the largest cancer center within a 250-mile radius, and it's a $140 million cancer center on the Edgewood campus. It's a beautiful building, 244,000 square feet, and we're anticipating opening up just next month in about 2 to 3 weeks to see patients. So we're extremely excited about it. It's really amazing to see this finally going from architectural renderings to reality. We'll also have a complete integrative and complementary medicine department to serve our patients. We're really excited about the state-of-the-art tumor board auditorium. Can't wait to sit in there and actually have a room that isn't kind of a closet of sorts to have our nodule review boards and tumor boards. So a big investment by the state of Kentucky and northern Kentucky with St. Elizabeth's new cancer center. And part of the reason is because Kentucky has a cancer problem. We have a huge cancer problem in Kentucky. Cancer kills Kentuckians at the highest rate in the nation. If you look at a map of the United States, the copper zones there are the highest incidence of cancer death rates in the country, and eastern Kentucky is a particular hotbed for cancer death. And if you follow Kentucky to the Ohio River and down the Mississippi River, you'll see that same level of bronze color. So if we look at cancer deaths in the United States, the average for our country is 189.8 per 100,000 population. Kentucky is down here at the bottom at 233.6 cancer deaths per 100,000. Clearly an outlier. And it's not just the impact that cancer has on our patients and their families and our communities. Lung cancer, or cancer overall, has a tremendous cost associated with it, estimated to be $174 billion in the year 2020. Now, if we look at estimated deaths from cancer in the United States for this year, it's estimated that 136,000 patients will die from lung cancer in 2020. and that's equal to or greater than the next 3 cancers combined, which include colorectal and breast. Kentucky has an even greater disparity. We're looking at losing nearly 3,000 lives from lung cancer in Kentucky this year, and that's equal or greater to the next 5 cancers combined, including colorectal, breast, and prostate, of course, which we hear a lot more about. And that has to do, to some degree, with the stigma attached with lung cancer. If we look at national lung cancer incidence, the national average is 59.6 cases per 100,000 population. Kentucky pops off the chart clearly at the bottom, an outlier at 92.6 per 100,000. If we look at this in a different way as a map of the United States, Kentucky on this map is the only copper-colored state. We're at the very top of this continuum at 93.5 lung cancers per 100,000 population. We're right in the middle of the tobacco belt, and unfortunately, we are in Marlboro country. Now, when it comes to national lung cancer survival, Kentucky is in the bottom tier again. We have a 5-year survival of 17.6% overall, and that compares to a national average of 21.7%. And as we know, lung cancer is directly proportional to smoking prevalence. The smoking prevalence in the United States actually just dropped from 17% to 16.1% of adults. And Kentucky and West Virginia have a death race to the bottom, usually competing. Right now, at this point, West Virginia is winning by a nose at 25.2%, and Kentucky is 23.4% of adults that smoke. If we look at lung cancer survival for 5 years and a spectrum, including all the different states, again, Kentucky is down here in the bottom tier. There's only 3 states that are down below us, and that's Alabama, Mississippi, and Louisiana. If we look at lung cancer survival rates, we know that if we can catch cancer in the earlier stages, there's a much greater chance of cure. If we catch patients in early stage 1, there's greater than a 90% chance of cure. So stage does indeed matter. As well, the cost is substantially different in treating stage 1 and 2 cancer versus stage 4 cancer. In stage 1 cancer, 45% of these patients can be treated with surgery alone. And the great majority of patients can be treated with surgery alone in stage 1. Well, as we get to stage 4, 2/3 of these patients require chemotherapy and/or radiation therapy. 32% of these patients, unfortunately, seek no treatment at all. And part of this is because the cancer is often so advanced that there really is not a treatment available, or that there is nihilism, which we all deal with in dealing with stage 3 and 4 lung cancer. And, I myself have even changed the way I approach patients when I see them now with stage 3 and stage 4 lung cancer. And there's a greater degree of hope for these patients with some of the newer treatments. Now, we use the CMS criteria for our lung cancer screening in our institution, and we're all generally pretty familiar with these. You have to be 55 to 77 years of age, have a 30-pack year smoking history, and you have to have smoked within the last 15 years. We are transitioning to the USPSTF recommendations that presently exist, and that's 55 to 80 years of age. We're going to start screening more to risk as opposed to insurance coverage. So how are we doing with lung cancer screening in our country? Well, as it turns out, not so good. Most of the studies that have been done over the last several years put the capture rate of the patients that qualify for lung cancer screening at about 4%. The American Lung Association in 2018 put us at 4.2% overall for the capture of the patients that qualify. Longevity just started giving each state a grade in February of this year. Kentucky got a grade of F. Indiana has a score of D, and Ohio has a score of C. And again, this is our tri-state area that we serve. We're hoping to improve that, of course. So lots of bad news. How about some good news? Well, there is plenty of good news as well. And one of the most interesting things that came out was a study the American Cancer Society did, and it was reported by Brianna Abbott in the Wall Street Journal in January of this year. And it was the largest recorded drop in cancer death rates from 2016 to 2017. And the cancer death rate actually dropped 2.2%, which was very significant. And the biggest component of that drop was the improvement in lung cancer. If you take lung cancer out of that equation, the drop was only 1.4%. And there's a number of different reasons for that. Of course, people are starting to smoke a little less. The screening has gotten better, and hopefully that will continue to make a larger impact. Radiation oncology and medical oncology has improved, as well as the surgical approaches to lung cancer. Now in Kentucky, we're very proud of some of the things we do. We breed the fastest, most beautiful racehorses in the world. We also brew and distill the best bourbon in the world. It cannot be disputed. If you go into any bar or pub or tavern in the world, chances are there's one of these bottles sitting on the shelf. Another thing we are starting to do better is lung cancer screening, as it turns out. We have now screened 10.3% of the eligible population in Kentucky. We are in the top tier of lung cancer screening in the country. We're very proud of that, and we hope to improve that. If we look at a spectrum of the states on average, and again, this is from the American Lung Association, the national average is 4.2%, and Kentucky is up here at 10.3%, only exceeded by 3 states, including Massachusetts, Vermont, and New Hampshire. And I suspect that our good friends at Leahy Hospital and Medical Center have something to do for that, as they're right in that tri-state area, and they have been pioneers of lung cancer screening. So we began laying the foundation for lung cancer screening at St. Elizabeth in 2013. Doctors Glenn Turner, a pulmonologist, and Gary Schmidt, a radiologist, began the program, and the administration and executive team quickly jumped on and backed the program. We were designated as a lung center of excellence by the American College of Radiology and a lung screening center of excellence by Go2 Foundation. In just April of this year, we were awarded the Go2 Foundation's Care Continuum Center of Excellence. I mentioned the executive and administrative support, and we've had a large-scale collaboration between the hospital system and the physician group. It's an integral part of our healthcare system to make Northern Kentucky one of the healthiest communities in the country. Smoking cessation is, of course, important, and lung cancer screening is playing a very integral role in this. We're in the process of establishing ourselves as a lung center of excellence, and this is a big part of it. It will be a big part of our new cancer center. So engaging primary care is very important, and we have to get the buy-in of the primary care providers, and we have to lower the barriers for ordering lung cancer screening and dealing with lung cancer any way we can. We were stuck on the bottom when this program first started back in 2013. This is looking at our progress in 2013 through 2016. And we were kind of bouncing around down here doing about 10 to 20 scans a month. And then Dr. Royce Calhoun was our first dedicated thoracic surgeon that joined our system in January of 2016. We started taking off shortly thereafter. I became the primary care advocate for our program toward the end of 2016, and we started taking off from there. We've used the LungRads program to grade the nodules that we find through our screening program. This program was originated by Brady McKee out of Leahy as well, and eventually was refined by the American College of Radiology. It stands for Lung Imaging, Reporting, and Data Systems, and nodules are given a category 1, 2, 3, or 4, depending on their diameter. We have a nodule review board, which is really what we consider to be a critical component of our program. We meet every Monday morning bright and early at 7 o'clock in the morning, and we review all category 4 lung screening nodules that are found, as well as incidental lung nodules and symptomatic lung nodules and masses that are found, which the radiologist tags as code lung management. We have a pulmonologist, a thoracic surgeon, a radiologist, myself, and nurse navigators from our lung cancer screening program, Megan Lockwood and Jessica Kearns, as well as a thoracic oncology nurse navigator, Stephanie Bonfilio, and they all participate in the nodule review boards and help to subsequently guide our patients through the program. Through this program, the recommendations are forwarded to the primary care provider, the patient, and appropriate orders are placed for any referrals or follow-up imaging that is required. I'm sure we're not alone in dealing with the barriers of smoking history in the EMR. We are constantly harping on our medical assistants as well as our providers to keep this smoking history accurate and up to date. It constantly changes. It seems like no matter how hard we try, there's always somebody getting in there and changing the data, but we work really hard to keep it up to date and keep it accurate, and it's really helped a lot. You know, it's education and really getting the word out how important this is. This is one of the slides that we use for the education of our medical assistants, and we really emphasize the start date. And this is the date that the patient very first started smoking and not a restart date. We also emphasize that the packs per day should be the average of how many packs per day the patient smoked when they were smoking full time. And then they can actually use a calculator if they need to figure out how many years the patient had smoked. And then Epic is our EMR, and it automatically calculates the pack years once these data points are entered. We have a lot of tools in our EMR as well that help lower the barriers and make this test as easy to order as possible. We have a health maintenance prompt that prompts the provider and or medical assistant if the patient is due for a lung cancer screening. We also have a BPA, which is best practice alert or best practice advisory, that pops up for the provider when the patient is due for a lung cancer screen. And you can enter the smart set through this window here, or you can enter it through your favorites. We also have our health maintenance and our BPA set up to capture any other qualifying CTs of the chest. And this is real important because if other qualifying CTs of the chest aren't accounted for, then the patient gets testing that they really don't need. If one of these qualifying CTs of the chest has been done, the patient really doesn't need a lung cancer screen for a year subsequently. So our system is built to account for these. So if you open up the Epic Smart Set, you can make it one of your favorites. You are prompted to enter a diagnosis, and one of these diagnoses, when they're chosen, is their diagnoses that insurance will cover. You can then enter the CT lung cancer screening smart set itself, and you have to indicate whether they're a current or former smoker, and the test automatically is entered for expiring in 1 year. By default, it says that the patient is asymptomatic, that you discussed the harms of low-dose CT lung cancer screening and the benefits. You've counseled them on the importance of adhering to an annual screen as long as they qualify. You have to counsel them on smoking cessation. And if they have stopped smoking, you have to emphasize that it's important that they continue to abstain from smoking. And then we have to check whether it's an annual or baseline screen. When we do all this and press order, a note is placed in the patient's chart, and it's personalized to the patient. The diagnosis is placed in the assessment and plan. And then at the bottom of the note, there is a customized entry that describes the patient, their smoking history, how they qualify, and that you did the proper counseling for shared decision-making, which, as we know, is required on the initial baseline lung cancer screen. If a provider tries to order this test and the patient is not qualified for the test, they get this big red window that pops up and says that they don't qualify for the test and they cannot move any further. We just put this in place about probably 3 to 4 months ago because providers were still ordering the test and sometimes the patient did not qualify. So this is a hard stop that prevents that from happening. We want to be really sure that we screen the patients that meet the criteria so that we're minimizing the risk. We also encourage our patients or our providers to use the G0296 code. You can use this code when you do the shared decision making, again, which is required on baseline or initial screens. If you do an annual screen subsequently, you don't have to do the shared decision making, but we encourage our providers to do the counseling if they have a chance, even on annual follow-ups. Doesn't take much time, and you can bill for it. We get 0.52 work RVUs when you bill this code. And it's another way of encouraging adherence for our providers. We have a number of shared decision-making aids. This is our Lung Cancer Screening Center brochure. We use the Kentucky Cancer Programs poster that Celeste mentioned early on. Most of our exam rooms in our system have this hanging on the wall or on the bulletin board. This is also sponsored in part by the Kentucky Leads Collaborative. We have another poster that we have in many of our exam rooms and that we hand out at fairs and healthcare events that talks about these same criteria. And it also has a section that talks about our retail program, which we base off at NCCN Group 2 criteria. We use the Tamamaji risk calculator that comes out of Brock University by Martin Tamamaji. And if a patient has a 1.3% or greater chance of getting lung cancer in the next 6 years, they qualify for the Group 2 screening, which is 20 to 50, there's 20 pack years and age 50 to 80. So we do a lot of work on reporting our progress. We feel that using data is extremely important to promote confidence in our program and to really convey how well our program is doing and to garner buy-in from the care providers. This is obviously too small to read in detail, but this is just a snapshot of the registry that Megan and Jessica compose every month. And then we have a summary slide that analyzes all this data on an ongoing basis, month to month, and keeps track of all the different categories of the nodules we find and the lung cancers that we find. And it calculates our false positive rate, which is 4.93% presently. It's really important that we distinguish between the false positive rate and the false discovery rate. It's often cited that, one of the detractants of the National Lung Screening Trial, which was published in the New England Journal of Medicine in August of 2011, had a false positive rate of 96.4%. That's actually not correct. Really, that's the false discovery rate. The actual false positive rate was 23.3%. And if the positivity cutoff is raised to 6 millimeters, the NLST used 4 millimeters for their cutoff. But if it's raised to 6 millimeters, then the false positive rate NLST drops substantially to 5.3%, which is pretty consistent with what we're getting in our program right now. So we find about 1.8% of our scans discover a lung cancer. In other words, for every 56 scans we do, we find one lung cancer. And that's a tremendous rate of discovery. It's really a valuable and effective test at finding lung cancer at a relatively low cost. We have a number of reports. These reports can actually be generated on a daily basis. We have a dashboard that the providers can access and find the same data. But we put this out quarterly to the oncologists and the primary care providers, and it ranks the sites from top to bottom based on what percentage of the qualifying patients have been captured. These are patients that are attributed specifically to a primary care provider. And these are our major primary care offices over here on the left. And this is the rate of capture here. This year to date, this slide's probably a couple months old already, 3 months old by now. I think we're approaching 15% or more. And part of that is, of course, because COVID slowed us down. We would have been higher than that. This is looking at the providers. So all the providers as well are listed from top to bottom and what site they're from. Same percentage, of course. And we have percentages at this point, mid-year, ranging from 30.7 down, of course, some around 0%. This is where we shook out the end of 2019. We had captured 36.3% of our patients that qualify for the test. And these are patients, again, that are attributed specifically to primary care providers. We had at the time last year, at the end of the year, 9,500 patients in our denominator. And we also have a system report that we run. And at the end of last year, we had captured about 30% of the patients in our entire system that qualified for the test. In our system, we have about 13,000 patients at the time. Another figure we track is how many patients have ever been captured, either by one lung cancer screen and or a qualifying CT of the chest. And we finished out the year last year at about 71.6%. One of our most valuable reports is what we call our lung cancer compendium. And we started this about a couple of years or so ago, and we went back and started with 2014 when our first lung cancer was discovered. And we keep track of every lung cancer patient that we have in our program, the demographics, their PAC years, which scan it was detected on, the date of the suspicious scan, what the category is, location, size, whether it was presented in the nodule review board, which early in our history, we really didn't have a nodule review board. And now almost every, or pretty much every case is reviewed in nodule review board. We have the date that the biopsy or diagnosis was obtained, and then the date that the pathologist actually signed off on it. We have the type of cancer and the stage of the cancer and whether there was a synchronous cancer or not, status, live or deceased. We have record additional workup and the treatment, and then the treatment initiation date, suspicious scan to treatment, diagnosis to treatment, and diagnosis to treatment as to when the pathologist signed off. We have response, complication, adverse events, miscellaneous, and then we also have put in here the age when the lung cancer screening occurred. We haven't quite started compiling exactly what their smoking status is, but we're going to go back and add that as well. What we'd like to do is see whether the patient was a smoker or not at the time of the scan, and then track whether or not they've quit smoking since they entered the screening program. And the nice thing is that we're working very closely with our IT and data analysts right now. We're compiling a database that's going to automate a lot of this. Right now, this is all done by manual extraction from the chart, which is extremely time consuming, but we are very close to having this automated. Again, this is too small to read in detail, but we have a colorized kind of summary rendition of the lung cancer compendium. And this is some blow-ups from that same snapshot. This is from the inception of our program. We found 68.6% of the patients that have lung cancer, either stage 1 or stage 2. And we're finding 57% approximately in stage 1. 2020 so far is looking like it's going to be a good year. We're finding 74% in stage 1, and we certainly hope that continues. We have an average PAC year of about 58. We keep track of the types of cancers, as I mentioned. This is the age distribution. There's one patient that kind of fell through our criteria here, but most of the patients, of course, are in the 55 to 77-year age range, and that'll change once we shift to the USPSTF criteria. Male and females are pretty much in a dead heat, right about 50% of each. And our diagnosis to treatment, and this is using the date the pathologist signs off, is 18 days. We have a very involved and extensive marketing department. If you go onto our website, there are several videos on lung cancer screening. You can take a quiz to see if you qualify, and it keeps patients updated on any promotions or advancements in our program. So we chart a path to success of our program. This is looking at 7 years of progress. This is 2015. As I mentioned, we had a hard time getting off the bottom. This is 2016, 17, 18, 19, 2020. I'm sure we're not alone. We had a terrific drop. We actually did just 13 scans in April. but we had a nice V-shaped recovery, and we had our two best months ever in July or August of this year, doing 431 scans just last month. This is another way of looking at our progress and some milestones. We found our 100th cancer in August of 2018. We found our 10,000th, or we did our 10,000th screen in October of 2019, and we found our 200th lung cancer in November of last year. We've now done over 13,000 scans. We did 4,082 last year, and there's an outside chance if the last few months are as good as the last couple months have been, and maybe a little better, we might possibly break the record we had in 2019. Fingers crossed. One of the slides that I get the most joy out of sharing is what we call our stage migration slide. And this is looking at almost 2,000 cancers that were identified from 2015 to 2019. The blue bars are the experience in our screening program, and the green bars are the experience in our non-screen patients. These are patients that are presented incidentally or that present symptomatically. And you can see that the blue bar in stage 1 far exceeds the green bar. We find 146% more lung cancers in stage 1 than the non-screen patients. And in stage 4, we find 72% less in stage 4. So 70.3% are found in stages 3 and 4 in the non-screen patients, and 67.1, almost 70% are found in the early stages, stage 1 and 2, through our screening program. So a tremendous stage shift, and this just really proves that lung cancer screening does indeed make a tremendous difference. So after the scan, we have a lot of processes and workflows and teams that are involved. It's important to have a primary care advocate that serves as a catalyst for the program. We had a lung cancer screening work group that initially met quarterly as we really started building our program pretty aggressively a couple, 3 years ago. And now we have a smaller lung cancer screening team that meets weekly. We also have a thoracic oncology disease management team that meets monthly. And we have a weekly huddle with our executive director of oncology, Doug Flora, our chief thoracic surgeon, Royce Calhoun, our chief thoracic oncologist, Getz Cloker, and our director of oncology services, Chris Carwich. And we meet and just talk about any advancements in our program that are pending or happening, any overlap of services that we can better designate, and any other topics of conversation. We have a strong quality transformation team that assists us in the value-based analysis of our program. We are involved in research. We have a continuous collaboration with hospital and physician executives that are in management, and we also have a monthly executive update of our cancer program. So education is real important. We have an annual symposium. Our 5th one is to take place November 11th of this year, and any and all are welcome to join that as well. We have presentations on a fairly regular basis. Anytime I can kind of nuzzle my way into the executive meetings, management, provider meetings, the PC leadership meetings. We have done many primary care visits, site visits. Now, of course, we haven't been doing too many of those this year with the COVID, but we look forward to getting back to doing that because that really helps when you can get out to the sites and talk with the providers in person at their provider meetings and welcome new sites that have joined, and we hope to be doing that soon. We have a very active provider outreach. I was just out of town for the last 5 days. When I got back, I had about 9 staff messages regarding patients that needed some attention that were sent from our nurse navigators, thoracic surgeons, radiologists, patients that were maybe screened out of criteria, or patients that maybe were referred prematurely. We really push our providers to be patient, and when they get a positive scan, we welcome them to speak with their patient and tell them about the results, but to really keep their finger off the button so they don't start ordering tests and referrals that possibly might not be necessary. We really want to have the knowledge review board have a chance at reviewing these cases and then making the recommendations to really improve the cost effectiveness and the time efficiency of their care and really minimize the risk as much as we can. So we talked a lot about the nodule review board. We mentioned our nurse navigators. We really consider them the glue for our program. They are really very involved in patient and provider communication and helping to garner the buy-in of the primary care providers, building confidence and trust. And there's a very good two-way exchange between the providers and the nurse navigators. Again, I emphasize the programmatic approach that we try to emphasize, and this also reduces the total cost of care. We have a lot of emphasis on retention, and we're starting to work with a vendor for incidental lung nodule program that's going to really, the software is going to really help us rein in what our actual adherence rate is. We have an intake coordinator that really helps to make sure that patients meet the criteria for our group 2 patients that I mentioned earlier. For our retail program, it's $99 if they fall outside of the CMS criteria that meet that criteria. And this is an algorithm just looking at the different team members and how the flow goes, how it feeds in the nurse navigator, and then goes to the nodule review board, and then recommendations are made from there. So I talked a bit about the lung cancer screening workflow, the orders placed, the patient schedule this through central scheduling, and then all the scan results are forwarded to the lung cancer screening nurse navigators in basket. I won't go into all the details of how each category is handled, but they each have a separate workflow and process map. So the ordering MD will be routed all the results. The patient will be reviewed at the nodule review board if they have a 4A or 4B. They will be contacted by the lung cancer screening nurse navigator either on that Monday or Tuesday following the review board recommendations. The recommendations are sent to the ordering MD, and they co-sign the orders if applicable, and then the patient receives a letter and or a call with the recommendations. So this is the role of the screening nurse navigator. We've talked about most of this. They compile the list for the nodule review board. They attend the meetings, enter the orders for follow-up scans, scheduling referrals, and they track the patients very closely to make sure they're getting appropriate and timely referrals and follow-up scans. We're often asked, when is the nurse navigator going to contact my patient by the providers? And these are the main reasons. If there's an incidental finding that's marked S on the low-dose CT scan, the category 3s, which mostly just usually need a 3-month or a 6-month follow-up, the category 4A, 4B, and any patients that are marked code long follow-up on incidental findings by the radiologist or symptomatic findings are reviewed. Code long management is a tag that is placed on screens that are done and require follow-up. And then, of course, anytime a provider or a patient has questions or requests. So these are some of the best practices, and a lot of these we've touched on already. The registry that the nurse navigators compile, the lung cancer compendium, our quality control, demonstration of stage migration, and then we do a lot of community outreach. We're really trying to get the good word out. Our marketing department, as I said, is very involved. We've had multiple outreaches through news media, both written and live. And our CEO of the hospital, Garen Colvin, I've never heard him speak in the last several years where he hasn't mentioned our lung cancer screening program. It's really been an important part of the success of our hospital and our cancer center. We speak at a lot of senior centers and fairs, of course, again, not many of those this year, but hopefully those will pick back up, Rotary and various clubs. And we're very involved in the fundraising arm of St. Elizabeth, the St. Elizabeth Foundation. One of the things that we've started to track and put some emphasis on is determining ROI, and that's return on investment. There's a lot of touch points that occur in the lung cancer diagnosis that are prior to lung cancer diagnosis, the screening and the testing and the pathology, incidental findings. And then, of course, after lung cancer is diagnosed, there's a lot of touch points that generate a tremendous amount of revenue for the system. And it's important to demonstrate this, really to sell it to the executives and the management, because if we can demonstrate significant return on investment, you're going to get much more support and buy-in, and secure the resources that are really necessary to build a successful program. There's estimates of about $700 to $750 per lung cancer screening of net revenue. If we used our 2019 estimate and we took the 4,082 lung cancer screens we did, that would be about $3 million that was net revenue if we use $770 per case. Our revenue program has estimated that we are about $211 per lung cancer screen. I don't really believe that figure, and we're working on finding where the errors or the shortfalls are. But even if we use that, we're at about $1 million of net revenue. So we have a team kind of looking further into that right now. And as we know, there's really three ways that lung cancer screening drives value. It's from direct revenue from the scans, there's downstream revenue that we talked about, and then there's the cost savings, which are a little harder and more intangible, a little harder to measure, but there's definitely a reduction in total cost of care and improved health. And this is going to be really important. Like it or not, we're all moving into a value-based market. So in summary, the top 12 best practices for engaging the primary care physician and everyone else as well are some of the tools we have through our EMR, the BPAs, the health maintenance prompts, making sure that we account for other qualifying CTs of the chest, ordering through the Smart Set, a standardized progress note that meets CMS and other insurance carriers' criteria, the use of the G0296 code for the shared decision-making work, and then performance and status reports, again, that are very important in conveying the status and success of the program. We have the primary care reports for both sites and providers. We have the system summary, and we have the dashboard that we update at least monthly. And really, as I've tried to emphasize, communication is extremely important. Just really trying to get the word out at every touch point we can find to take advantage of. And, as part of that, of course, is educate, 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 and then demonstrating and refining the return on investment. So thank you very much. I made it within my allotted 40 minutes, and I think Celeste is going to take over at this point.
Thank you so much, Dr. Gieske. That was incredible how quickly you got through all of that. That's impressive information and statistics that you've shared with us, and I hope that gave some great examples to a lot of other screening programs that have either been screening for quite some time or are developing and growing. So I appreciate you sharing all of that success, and it's certainly a model for the rest of the country to be able to follow. I do want to let participants know that you're welcome to submit questions to Dr. Gieske through the Q&A box, and we will do our best to answer as many of those as possible in the time remaining. While participants are submitting questions, I just want to quickly share information about a couple of key offerings from LUCA. The first being that we recently completed a significant update to our free award-winning online course, Lung Cancer and the Primary Care Provider. This video-based course covers lung cancer care across the continuum in 3 separate modules. It provides free CME, nurse practitioner specific credit, or AAFP prescribed credit for family physicians, and is available to anyone. And I want to just let people know, if you are interested in sharing that course overview with others in your medical organization or health system, we'll be happy to send you a link to that course. And as a reminder, for those of you who may have had to join us a little bit later, if you are interested either in the certificate for attending today or the materials that you can obtain from LUCA, either through hard copies or digital versions, or when we release a new infographic regarding lung cancer and lung cancer screening, just provide your email address in the Q&A box to the bottom right, and we'll be happy to follow up with you with that certificate or those materials and honor your request. So with that, I think we can go forward now with asking our speaker some of the questions that have been submitted, and we will start with those that were provided when people registered for the webinar. And so with that, Dr. Gieske, I will start with what proportion of screened people are still smoking? Please discuss your efforts at helping these long-term smokers quit successfully.
Again, we are in the process of determining that figure, but, probably in St. Elizabeth's system, we're in the 20 to 23% percentage of adults that smoke. Now, it's been proven repeatedly that just simply entering a screening program makes the chance that the patient will quit smoking much more significant. And we're hoping to very soon prove that once we get the data in, but we really haven't analyzed those numbers yet.
Okay, that makes perfect sense. This is a little bit exceptional for the time period that we're in. What would you say the impact of COVID-19 is on people with compromised lung capacity?
Well, it's extremely impactful. Patients that have chronic lung disease are much more likely to be affected and get pneumonia and unfortunately pass away from COVID.
Well, I know it's been a unique time to keep screening in the mix for those that are at higher risk, but would you say at this time that people should make sure that they're getting the screening as much as ever now that protocols are in place for addressing COVID in facilities?
Absolutely. We, of course, shut down our program for a couple, 3 months, and we gradually started ramping it back up in May. And we have lots of safety measures in place to assure our patients that, they are being taken care of and that the risk of contracting COVID through our facility is essentially nil. And, we've been pleasantly surprised how many patients are coming back. Who knows how many, if COVID didn't happen, we'd be doing per month right now, but we're pretty pleased that we're surpassing 400 screens a month at this point. And I think it's because we've really conveyed to our patients that, their safety is in our interest as well.
Well, you should be very pleased with that. Your numbers are highly exceptional and shows you're doing a lot right. Since we're in Kentucky, I'll pass along this question. What considerations related to building a lung cancer screening program are unique or intensified in Appalachia? Do you have any comments on that?
Well, sure. As I mentioned on that one particular slide, the death rate from cancer is extremely high in Eastern Kentucky with a death rate of over 500 per 100,000. And that's an area that, we have an interest in as well. Even in Northern Kentucky, one of the Appalachian Regional Hospital is one of the members of the Kentucky Health Collaborative. We're working with them to try to, improve their screening rates as well. And we're working collectively together to improve the rates of Kentucky as a whole. There's some interest, especially from that region and some other regions in the state, at eventually getting a mobile lung cancer screening van, and actually kind of a network of vans eventually that will be kind of sponsored and driven potentially through the Kentucky Health Collaborative. And obviously that'll help with our outreach into these rural areas, especially, for example, in Eastern Kentucky.
That would be great. Another one is, how are you reconciling the need for low-dose CT lung screening eligibility and increasing awareness for PCPs? Because they said there's such a disconnect with the approximate 4% of eligible patients actually receiving screening.
Well, a number of things. I think, in summary, the most important thing is communication and education, just really taking every chance you can to get the word out. And, as I mentioned, we use CMS criteria, and we're expanding the USPSTF criteria. And, the USPSTF just recently came out with some draft resolutions, which we responded to through several channels. But, chances are that that range will be expanding, from 55 to 77, or 55 to 80 to 50 to 80 years of age. And they're probably going to lower the PAC years to 20, which kind of mirrors our present retail program. But again, we use the Tamamaji risk calculator for our retail program. And if their risk is 1.3% or greater, that they will get lung cancer next 6 years, and they meet the criterion for our expanded program.
Okay, and I think we just have time for one more question, but I do want to let everybody know that all the questions submitted will receive a response separately. And this person asks, how are patients notified of lung nodule review board recommendations? Does Navigator contact patients personally?
Yes, absolutely. Those patients are given a phone call by our nurse navigators, and they are personally spoken to about the results of their scan. Some of the patients are, we know that there's some providers that want that opportunity, so sometimes they'll wait a day or two for those providers that really want to be more integrally involved. But all in all, the providers have been greatly accepting of the program we have and are very confident in the job that our nurse navigators and our program does.
Well, thank you so much for answering those questions, Dr. Gieske, and for all the other information. Those are all the questions we have time for live responses to today. Thank you for everyone who submitted a question, and we will be in touch with responses to those that weren't answered. There will be a brief evaluation for the end of the webinar that when it's ended, we would greatly appreciate your responses to those so we can continue to provide the needed education such as this going forward. Also, the slide set and recording of this webinar will be available on the Dialogue for Health website in about a week. If you shared your email address with us during registration, we will be able to send the link when that becomes available, or right now you can go ahead and submit your email in the Q&A box to have a notice of that sent to you. Thank you again for your participation, and please be on the lookout for the next webinars in our series. Have a wonderful afternoon, everyone.